Okay, all right. So we should have who's gonna present? Give me 1 second. Let me grab a. All right. Fine. Okay, who's the presenter?
I'm the presenter for today.
All right. So again, this is not ideal, This is not ideal, but I think there's not much way that we can do with this. But I think okay, let's make do with whatever we have, inshallah. Okay, Fadha, let's start.
Okay. Can you see my slides?
Yes.
All right. Okay. Okay. So my chief complaint is this patient, Muhammad Shakil, a 9 years old Malay boy with no non-medical illness, was presented to HTA with seizure for 1 day duration. So for history of presenting illness, he was apparently well until the day of admission, when he suddenly developed first episode of generalized tonic-clonic seizure. So practically, the patient had a episode of non-projectile vomiting once with minimal amount of watery content. There is, however, no blood or bilious content, and there is no aura practically. There were also no triggering factors like flashing lights from the TV or sleep deprivation. So the episode of seizure started in their house at 7 a.m. When all of his limbs became stiff, lasting for 5 minutes. Then he developed a jerky movement of his limbs continuously. So the seizure was associated with fixation of the eyeball to the right side, drooling of saliva, and loss of consciousness. Otherwise, there was no lip smacking, there is no tongue biting, and urinary incontinence. So on further questioning, there were 3 episodes of seizure with a 5-minute interval in between each of the episodes. However, the child never regained consciousness, or there is incomplete recovery lah. So the total time of episodes lasted for about 40 minutes before the administration of medication at the ED of HTA. So post-ictally, he regains full consciousness, but still there is some residual dizziness. There was, however, no weakness of the muscle. The child is not drowsy and is not sleeping after the seizure. So further questioning, he had developed an intermittent headache for 1 year prior to this admission. So it is generalized. Is generalized, however, more prominent on the right side of the head. It is throbbing in nature, aggravated by activity and released virus, and the child scored the pain as 6 out of 10. So within a month, he usually have around 1 to 2 times episode of headache. However, 1 week prior to this current admission, the headache become frequent, which is 1 to 2 times per day. Otherwise, 1 week prior to this admission, all the characteristics and the intensity of the headache is the same as initially 1 year ago, and it it does not resolve with intake of paracetamol, and there is no other drug history. Otherwise, this patient has no history of fever, photophobia, neck stiffness, or change of behavior noted by the parents. There was no loss of weight or loss of appetite. There was no yellowish discoloration of the skin. There was no rash or joint pain. There was no diarrhea or polyuria. There was no history of hunger, shakiness or tremor or palpitation. There was also no history of head trauma, and there is no contact with sick patients. So for past medical history, this patient has no non-medical illness, no history of diabetes mellitus, no other there is no non-medical illness. And then for family history, his sister had a history of febrile fit 1. Otherwise, there is no significant family history like family history of epilepsy, hypertension, autoimmune disease, or malignancy. And then for development, this patient is up to his age, 9 years old. Immunization is up to his age. Birth history is uneventful. He is delivered through spontaneous birth delivery. At term, 3 kilogram of weight. No complication parentally like prolonged labor, uh, user, any instrumentation or any trauma during delivery. So socialist, his father is 43 years old, driver. The mother is 38 years old, cashier, with a total income of 2,500 ringgit. This person is the fourth sibling out of 6. And then he lives with his family in Kampung Sungai Pancing, in a kampung house that is complete with basic necessities. Okay, that's for history. Then we go to physical examination. So physical examination, the child was conscious and alert. He had no dysmorphic features and also no neurocutaneous lesion. Oral and peripheral examination revealed normal findings. For vital signs, the patient was febrile, non-hypertensive, and other vital signs are also normal. On neural examination, his DCS was full. The muscle tone, power, and reflex were normal for upper and lower limb. Babinski sign was downgoing with absence of clonus. Brzezinski and Koenig signs were also negative. His cranial nerve intact. Otherwise, other systemic findings were unremarkable. So, summary for summary in this patient MS, a 9 years old Malay boy with undiagnosed intermittent right-sided headache for 1 year, was presented with generalized tonic-clonic seizure of 3 episodes lasting 40 minutes with no complete recovery in between attack. It was associated with 1 episode of vomiting, uprolling of eyeball, drooling of saliva, and dizziness. On nervous examination, on nervous system examination, it was normal. Babinski sign was downgoing, clearance was absent. Koenig and Brzezinski sign were negative. Okay, so I think Doctor, I can hear you.
Doctor, you forgot to unmute.
Okay, fine, fine. Sorry. Okay, stop the slide share. Okay, all right. So we have 21 here in this group. Other than me and the presenter, we have 21. Okay. So what I want from everyone is, okay, you've listened to the presentation. Okay, what I want from everyone is, you tell me from what he has presented, what do you think is the provisional diagnosis? What are the differential diagnosis? So fifth year, I expect fifth year, kan? So fifth year, I expect at least 5 differential diagnosis. So you tell me what is your provisional diagnosis and why that is your provisional diagnosis. Give me 5 differential diagnosis, why and why not, and comment on his presentation. If it's good, why is it good? If it's not good, why is it not good? Okay, right, fine, boleh, yeah, okay. So boleh, can we start from the start from the first one? From my screen, the first one is Farah. Okay, boleh start.
Okay, so the first differential diagnosis will be epilepsy. Point 4 will be because the patient is first presented with seizure, and then and also the according to physical examination, it also have a positive finding. Itulah positif. Saya okay, and also the and for however point against it is due to the I want to confirm which is it the first presenting tadi.
Yes, this is the first presentation.
The point against it will be because it's the first presentation for the child.
But what's the question again? Sorry.
The first presentation for the child, just then the seizure episode.
Yes, this is the first presentation lah for the child.
So that will be a point against for the epilepsy because usually epilepsy it is few the patient be previously already presented episode of seizure. I think that's all from me for now, Doctor.
So differential only one.
Oh, okay.
So what is the provisional diagnosis, differential diagnosis, and comment on his presentation? Mute dah Farah. Mana?
Sekejap, Doktor. Saya differential will be...
Okay, tak apa. Farah, okay. Let's stop.
Okay,
Sebelah, I will get back to you after this. Okay, the one next to you is Nur Zakira Imana. Lepas tu Syahirah Kamal. Lepas tu Nur Hazikah. Lepas tu Alia Azhari, Hasan Nasri, Fathul Hakim, Fatihah Hamid, Zahra Najwa, Izzah, lepas tu Amirah, lepas tu Hafifi, lepas tu Zain, lepas tu Wan Nur Syamimi, lepas tu Azlan, Maisara, Aisyah, lepas tu Siti Izzatul. Okay, alright. So let's go to Nur Zakira Imana first. Provisional differential comment. Yeah.
Okay.
Hmm.
Okay, dengar ke suara?
Dengar.
Okay, so I think for the provisional diagnosis might be epilepsy. Because sorry that I'm not sure, but for differential diagnosis, I think it could be febrile fit because this is the first presentation, but there is no association with the fever or previous or predisposing infection, and however there was no family history of febrile fit in the family. Then other differential diagnosis could be meningitis or encephalitis because the patient have the presentation of the headache, but the headache is chronic, so it is less likely. For the for the presentation, I think it is good
If you think it's good, why is it good?
because he explored the uh, he explored the pre-ictal and then the ictal and the post-ictal part because it is important and but I think he should explore more on what trigger the patient to have a seizure because it suddenly have a seizure.
Okay, you know why I do this. If you have long case presentation with me, this is how I'll do everything. So one person presents, and then we'll go through provisional, differential, and comment from everyone. Why? Because this will show us. It will test both. It test the presenter and test the listener as well. So if your presentation, so why do we present a case? Why do you, a medical student, present a case? Why do you later on as doctors present a case? Why? What is the purpose of presenting a case? Because you will be doing case presentation your whole life, kan? A doctor, kan? So why? Why do we present cases? What is the purpose? What is the objective of presenting a case?
To sell provisional diagnosis.
The first objective of any
Share information.
is to sell your provisional diagnosis, is to reach to the provisional diagnosis, is to get to focus on your provisional diagnosis because we manage cases based on the provisional diagnosis. How we manage the case will depend on what is our provisional diagnosis. So the first objective is to sell, is to focus, to zoom in, to get to our provisional diagnosis. That is the first objective. What is the second objective? Second objective of any presentation. The second objective is to rule out differential diagnosis. Because as doctors, we need to always think, probably there is something else that we have missed. Probably there is something else that someone else has missed. Probably there's something else that the first doctor that clerked the patient have missed. And we should work for the best of the patient. So the only way for us to do is actually to rule out other differential because this is our job. This is our job to rule out the differential diagnosis because patients can come with so many diseases, can come with so many illnesses, and it is our job to look for what are the differential diagnosis, to confirm the provisional diagnosis, and to rule out all the differential diagnosis. You can only ask appropriate question. You can only ask the correct questions if you know what are the provisional and what are the differential diagnosis. If you don't know what are the differential diagnosis, how can you ask appropriate questions? You won't know what to ask. You tanya sikit, lepas tu you pun dah blur. Sebab apa you blur? Sebab you tak tahu, you don't have idea about the differential diagnosis. So these are the first two objective of any presentation. What are the other differential diagnosis? The other objective of presentation. So one is to get to your provisional analysis. Second is to rule out differential diagnosis. Third, what is the third?
For complications.
Management.
Look for complications of the disease, because all disease has complication. Nothing in this world does not have any complication. Everything in this world have its own complication. So all diseases has its own complication. Nothing in this world does not have any complication. So everything has its own complication. So as doctors, we need to look for if the disease has actually caused problem, if the disease has caused complications. So we need to look for the complications of the disease. What is the fourth objective? Last objective.
For management.
Look for complications of the treatment, because especially if the patient was admitted and then you clerk the patient on day 2, for example, some treatment may already has been done, and those treatment, all treatment has its own complication. Even not doing anything has complication. Not starting antibiotic has complication. Starting antibiotic has complication. Giving vaccine has complication. Not giving vaccine has complication. So doing things and not doing things both has its own complication. So as doctors, we need to look for all those complications. Bagi air kosong pun ada complication. Kan? Everything you do and everything that you do not do has its own complication. So as doctors, we need to look for all those things. So number one, proof, get to, focus, zoom in, sell your provisional diagnosis. Second, rule out all the differential diagnosis. I expect at least 5. You should actually, fifth year, you should have at least 7 differential diagnosis. Kan? Lepas tu, number 3 is to look for complications of the disease. Number 4, to look for complications of the treatment, because everything has its own complication. If you clerk the patient, even if you clerk on day 1 of admission, tapi you clerk in the ward, someone may have done something at ED, kan? And that something may have its own complication. Even if you are in ED, someone may have done something masa patient dekat GP, kan? Patient selalu pergi GP dulu, lepas tu baru pergi hospital. So someone may have done something. Even kalau you dekat GP, probably patient dah tanya kawan-kawan dia, ada Facebook group ke apa benda kan. Probably the patient have done something. Kan? And that something may have its own complication. Kan? Parents may have Googled the problem. Kan? And parent may have done something with Googling. Kan? Parents may have brought the child to bomoh dan sebagainya. And all this thing has its own complication. So as doctors, we need to look through all those things. So those are the objectives of presenting a case. So your presentation should cover all 4 elements. Your presentation should be focused enough, should be directed enough, should be targeted enough that people listening to you will clearly understand, oh, okay, this presenter is trying to direct us towards this provisional diagnosis. This presentation is actually showing us this is the provisional diagnosis. If you present a case, your listener tak ada idea what is your provisional diagnosis. So it shows that your presentation pergi ke laut, pergi ke langit. Hala tuju dia orang semua tak tahu. Faham tak? Kalau your presentation is good enough, is focused, targeted enough, people yang dengar boleh tahu, okay, so this is the provisional diagnosis. Kan? Unless kalau your listener semua tak erti apa lah. Kan? But you are all from the same group, from the same, you all should have around the similar level of clinical knowledge. You all should have around the same level of clinical judgment, clinical acumen. So in that sense, I expect if one of you present and the presentation is good, targeted enough, everyone should get. So this is where you are headed. Semua orang tahu dah nak hala tuju dia ke mana. Kan? So, tapi kalau semua orang bagi provisional yang lain, so it shows that your presentation is pergi ke langit lah, hala tuju dia tak tahu ke mana. Pusing. Kan? Sama juga dengan differential. If your colleague, if your kawan-kawan semua struggle to list out differential diagnosis, it probably shows that your presentation ni is not robust enough. Terlalu narrow. Kan? Differential dia tak berapa clear. Kan? So you all have similar level of knowledge, similar level of clinical acumen and clinical judgment. So bila orang present, those of from similar group akan tahu dah, okay, so these are the things that the presenter is trying to rule out. Kan? Unless kalau presentation tu tak berapa clear. Sebab presenter pun tak berapa sure differential apa. Kan? So that shows that's a problem. Kan? So a good doctor always think about differential diagnosis. Even though professor yang paling besar tanpa ke bumi ni dah bagi that diagnosis, a good doctor will always think, is there any other differential that we should have thought of? Is there something else that we have missed? That's how we work. I will always say this example which I have faced myself. Ada sekali tu we were doing rounds with one lecturer. So the managing team, so I was in USM. So managing team already diagnosed this patient with one disease. This management because from that particular disease. Lepas tu bila student ni present case to as long case, kan? That particular student being a very good student was very thorough. Kan? Presentation dia very thorough. Kan? Very good differential diagnosis. And daripada that thoroughness of examination, kan? Dia boleh dapat satu differential provisional diagnosis yang lain, different to as compared to what has been treated before. Patient tu dah beberapa hari dalam ward, tapi tunggu medical student ni club and present, baru nampak diagnosis dia different. And finally after that presentation, the whole diagnosis for that patient was changed. The treatment was also changed. Daripada patient tu kena stay lama kat ward, diagnosis dia change. Prognosis will differ as well. Why? Because one good medical student. So that is how you should do as medical students, as doctors. So we need to look for provisional and differential. We should always think about differential diagnosis. Walaupun kita dah tengok dah sebelum ni, next time kita review patient yang sama, kita still nak kena fikir what are the differential diagnosis, what are we still missing. And we should always look for complications of the disease and complications of the treatment, because everything has its own complications. We do not just treat patient, we treat a human, and human being has its own problem. That's what we should do. Okay, so this is why if you should, I'm assessing both. Satu sama ada the presenter, and also I'm assessing the listener as well. And the thing why I always ask for comments is that is the way how we can improve. That is the way how we can improve. If you think it's good, tell the presenter, I think your presentation is good because this and this. Because we can only improve if we know what is good with us and improve on the goodness that we already have. And we can only improve if we know what is wrong, what is lacking, what is faulty with our presentation. So that is why if you think it's not good enough, if you think there are elements that the presenter should have mentioned, so tell him, presenter, I think it's good, but I prefer if you mention like this and this. I prefer this, the part you mention this tak berapa clear. Dah ada slide pun tak berapa clear. Kan? Macam mana kalau present tanpa slide? Lagilah tak clear. Kan? So this is what I expect you to tell, because this is how you can improve. Kan? We cannot improve ourselves. Kita tak boleh tiba-tiba dia jadi baik. No, we can only improve if someone told us this is wrong. This is not wrong lah, but you can do it a bit better. So this is how we improve. Okay, Aci Mak Labu. Okay, alright. Zakira, tak habis lagi tadi. Sampai mana dah? Tidur dah budak ni, nampak?
Komen
Khairah tadi
I think for the presentation, it is fair enough to show that the boy was presented with the seizure, and he had covered about the pre-ictal episode, ictal, and also post-ictal. However, I would like to know more on the what triggered the seizure because he just mentioned before he only said that no triggering factors such as passion, light or sleep deprivation.
Okay, alright. Fine, Syahira. Lepas Syahira kita balik pada Farah.
Okay, so my provisional diagnosis is tonic-clonic seizure, and for differential,
Tonic-clonic seizure is not diagnosis. Tonic-clonic seizure is a presentation. Macam fever. Fever is a presentation. You cannot say my diagnosis is fever. Tahu lah, fever orang kampung pun tahu. Mesin dekat TMG tu pun tahu kan. So tonic-clonic seizure is a presentation. Hypoglycemia is a presentation. That's the diagnosis. Okay. Ulang balik.
oh,
Okay. Go to your differential then. Differential. Lepas tu kita patah balik provisional. What are your differential?
my differential,
Hmm.
I would like to think of other causes such as metabolic causes, such as hyponatremia, but this is less likely sebab kalau based on history, dia tak ada any history of GI problems that can cause loss of water ataupun cause dehydration. So macam itulah hyponatremia.
Dia ada vomiting?
Tak ada.
Dia ada vomiting kan?
Ada one episode of vomiting.
Only one.
Yes, only one. Watery content.
So did you ask the presenter, is this the only vomiting yang ada? Has the patient been vomiting past few days ke?
There is no episode of vomiting prior to that one episode.
Alright. Lagi apa lagi? Berapa tadi umur patient berapa?
9 years old.
Apa lagi Syahira?
So, okay. Tadi hyponatremia. Selain pada tu, maybe it could be hypoglycemia that can cause the seizure. And selain daripada tu, I would like to think of
So
trauma.
if you think it's hypoglycemia, what else you want to know?
In hypoglycemia, I would like to know further about dia punya diet dia ataupun adakah dia makan sebelum
Okay.
macam mana pemakanan dia.
Tanya. Syah ada kat situ je. Tanya.
So Syah, I would like to know further about the patient's diet. Did the patient eat prior to the presentation?
A better question will be how was his diet that day? Kan? That day tu macam diet dia macam biasa ke? Any change of diet ke? Dia still makan lagi tak that day? Ataupun the whole day he's not been eating anything?
Actually, I forgot to put in the slide. This patient diet tu on that day, his last meal was around 11 hours prior to the seizure.
So he's not been eating for 11 hours, not taking anything for 11 hours.
Yes.
And then vomit pula tu. Nampak? When you ask appropriate question, you'll get good answers. Okay, apa lagi nak tanya?
Kalau nak tanya,
Tanyalah follow up on that. If the patient then bagi tahu, okay, 11 hours dia tak makan, what else you should ask?
yang masa 11 last meal dia apa yang dia makan, and then dia tak makan tu, ada dia minum air tak, any air manis ke dia minum dalam masa 11 hours tu, why dia tak makan?
Okay, better question. Yep, okay.
Actually, I'm also not sure why the patient did not have any order intake for 11 hours. And the owner of this previous caser app only mentioned that prior to 11 hours tu he only eat lightly and drink water lah. In interval tu he did not explain this patient take any like sips of water ke he did not explore on that.
So why? You're not clear why is it patient not taking any.
I'm not sure why patient is not.
Do you think that's important?
Yes, I think that's important because it could be the cause of the seizure.
Okay. Apa lagi Syairah? Apa lagi?
Differential lain tu macam mana tu?
Baru satu differential.
Dua?
Dua.
Lupa
Okey,
natriumnya.
dua. Ada tiga lagi.
Uh,
Dua
ya.
dari semua metabolik kan? Cerita. Okay.
So yang lain I would like to think about trauma, tapi kat dalam history pun dah cerita yang patient ni tak ada history of trauma. So kalau trauma, I would like to think kalau any yang boleh cause increase in intracranial pressure. And fever seizure pun tapi dah betul dalam history tak ada fever. Then selain daripada yang tu,
Lagi lain betul? Okay lah, comment on his presentation.
So kalau comment on his presentation, yang sebenarnya lebih pada belakang-belakang sikit lah. Macam social, I like that they presented about the family punya working and dia punya adik-beradik yang keberapa. Tapi I would like to know further sebab patient ni represented with headache. So what about his school performance dan macam mana headache tu affect dia punya daily life dia? Sebab headache tu is quite long time kan, setahun dah. Itu je lah.
Tanya. Dia Syah boleh jawab lagi tu.
Saya nak tanya macam mana dengan patient tu punya, dia punya school performance.
And school
Sebab,
attendance.
School attendance, performance and dia punya interaction with friends.
School performance, I'm not sure. However, there is some problem lah when communicate with friends and interaction with friends too. Sometimes it's disturbed because of the headache, because it sometimes occurs suddenly in the past 1 week prior to this presentation. Performance, I'm not sure, however.
School attendance. Has it been severe enough that she or he?
He.
Is it severe enough that he can't go to school? Sekolah kena telefon parents suruh datang ambil dia. Because if the headache is bad at school, what will teachers usually do? Teachers will definitely call parents kan?
Akan hantar balik rumah.
Tak teacher tak ada hantar sendiri kan? Jarang ada teacher hantar sendiri. Ada ke? Korang ada teacher hantar balik rumah? Tak ada kan?
Ada.
Ada?
Saya dulu kecil-kecil selalu kena
sakit kepala? Ada
headache.
seizure tak? Tak ada seizure?
Tak ada seizure lah tapi.
Muncul. Boleh lah, cikgu dia baik-baik. Sekolah mana? Cikgu tak hantar. Cikgu call parents lah kan untuk ambil. What else? Okay, let's go to the next. Tak habis kita ni kan. Izzah. Tak. Tadi nak pergi kat Farah balik kan? Farah. Cepat.
Ada differential ke doktor?
Differential and comment.
So another depression would be whether the patient have any infection causes like meningitis or encephalitis. Tapi for point four it will be um point four it will be the only the headache episode and also the seizure episode. However, the patient do not have any point against. The patient do not have any history of fever or any acute infection prior the episode. And another point for will be tadi Shah already said that the patient do not have on physical examination tak ada neck stiffness ataupun basically the neurological there's no any neurological sign, so that will be point against if it's we suspect for meningitis or encephalitis. Betul. Okay, that will be another depression. Um, uh, comment ke okay. Comment for the presentation probably macam in the history ada Syah ada is there any macam um history of the child sibling or dekat sekolah yang ada children yang ada symptom of infection ke? Saya dengar ke?
Ada. For this patient, there is no similar symptoms like signs of infection in his other classmates.
Okay,
But,
alright. Fine.
alright.
Izzah, tak habis kita dengar.
Saya rasa komen, kita tak ada komen sangat untuk for the presentation. I think it's generally okay. Itu lah.
Why? Okay, why okay? Okay, tak apa. Farah,
Because-
we'll get back to you. Think dulu. Then kita get back to you.
Okay.
Cepat. Izzah.
Okay,
Lepas ni
First-
Hamizah.
for comment, the presenter Shah has quite good in presenting about the seizure itself. But I would like to know more about the complication of the seizure because the seizure is quite long, so maybe there is complication like tongue biting. Okay. And next is for provisional diagnosis. So my provisional diagnosis is hypoglycemia. But for this hypoglycemia, I would like to know also about how the patient recover. Is it from the only after the medication given the patient recover from the seizure? Because I think for hypoglycemia, if the treatment is giving glucose, right? So like if we give glucose, the patient may recover. Betul tak? Okay, and next differential diagnosis.
Give time for Shah to answer.
Okay.
Shah, you want to comment?
This patient regain consciousness in the ED lah after the administration of the what is called of the antiepileptic drugs, and then for from the history at the ED there is no administration of uh, uh, dextrose saline or any dextrose to help this patient recover from hypoglycemia. I did not get any history of that.
Okay, thank you. Okay, for differential diagnosis. For differential diagnosis, my first differential diagnosis is brain tumor because the patient has suffer with headache for about 1 week, 1 week, 1 year, and it become more frequent recently, and then it come with he come with seizure. Also, with the vomiting is point 4 space occupying lesion. My other differential diagnosis is meningitis or encephalitis, which is infection. The points again is no fever and normal neurological findings. Next, differential diagnosis is electrolyte disturbance. So for electrolyte disturbance, maybe we should know more about the vomiting because if we think the electrolyte disturbance due to vomiting, the vomiting must be massive or yeah, because it is only one episode, right? And that's all.
Okay, all right, Hamiza.
Yes, doctor. Okay, my provisional diagnosis is actually I would like to put status epilepticus. But before that, I would like to know is this patient actually is this recurrent episodes of epilepsy or seizure, or actually this is the first presentation? And then if this patient is actually having any underlying diseases, like this patient has been diagnosed with epilepsy or not, because I think you only mentioned that this patient does not have diabetes. Okay. The reason why I put this is status epilepticus is one is because of the durations of the seizure, and then the episodes of seizure. We have 3 episodes of seizure, and while this patient the interval between those 3 seizure is 5-minute interval, but patient does not regain any consciousness in between that. And then Shah, I would like to clarify what is meant by the total times of episode lasted for about 40 minutes before administrations of medication, and what type of medication was administered, where, who?
Okay, so total for your last question tadi, 40 minutes tu is the total time, total duration of the 3 episodes of seizure, including the interval. And then the medication was given at the emergency department lah, because this is the first episode, and this patient has no previous has never been previously diagnosed as epilepsy. And then you asked about the medication. So he was given intravenous diazepam and phenytoin at the ED in HTA.
How far is the house from HDA? You know why I asked this question? Because sometimes in HDA, looking for parking takes you half an hour. Kan? And if the seizure aborted after that medication, I presume diazepam lah, Valium. Kan? Registration, getting from car to the red zone, and then preparing the drugs, that's going to take time. Kan? So, the question you should have asked, the past 4 of your colleagues should have asked is, what was done actually? What when the child had that seizure at home, what did the parents do? Where were the parents? What were the child doing? Dia ada vomit. Yes, fine. How long duration between vomiting tu? Dia vomit dekat mana? Vomit dengan seizure. How far was the distance? Any triggering to the vomiting? Can the vomiting be actually an aura? And then what else? What did the child felt before the vomiting? What happens in between vomiting and seizure? What was the child doing masa seizure tu? After vomit tu, dia rasa macam mana? Dia sakit tekak ke, sakit kepala ke, sakit macam mana ke, sakit badan ke? Was the child lying down? Was the child asleep? And then just prior to seizure tu, dia tengah buat apa? Kan? And then masa seizure tu macam mana? Ada history of fall ke? Seizure sometimes causing the child to fall kan? Dia seizure tu pula dekat mana? Atas jalan ke? Atas simen ke? Atas rumah ke? Atas katil ke? Apa? Atas apa? Seizure tu. And then what did the parents do? Because parents reported history tu very quite clear kan? 5-minute interval apa semua. Kan? 5 minutes is quite long. So after berapa minit? After which seizure parents decided to bring to the hospital? Kan? Macam mana angkat masuk kereta? Dengan kereta ke atau parents call ambulance? So what happened there? Lepas tu sampai hospital tu at berapa minit? Masa sampai tu seizure still going on ke? Ataupun similar semiology? Do you have any answer to those questions?
I don't have all, but some. The patient during the seizure attack, he was actually in the toilet and then I'm not sure how long until the parents noticed he is unconscious in
He's
the
in the
toilet.
toilet doing what?
Showering. I think from what I remember, I think it's showering.
Don't think. If you're not sure, tell you're not sure. Tak sure.
I'm not sure.
Okay, fine. Okay, Hamizah habis dah ke? Tak habis lagi kan? Lepas ni siapa ni? Tak nampak nama lah. Siapa? The only other male that pasang kamera ni. What's your name? Nama tak keluar kat sini.
Hassan.
Hassan Nazri. Okay, after this you Hamizah, cepat. Okay, tak habis kita kan.
My provisional diagnosis is meningitis, given the history of a headache 1 year, but there were no other symptom that suggest
Meningitis, headache 1 year.
tu macam less likely because headache 1 year. Oh, pasal headache tu does he seek
So can meningitis present with headache 1 year?
less likely.
Cannot lah, bukan less likely, cannot lah.
Ada difference diagnosis is electrolyte imbalance. Yeah.
Okay, comment on his presentation.
I think I can see that you try to arrange the history according to the event in pre-ictal, ictal, post-ictal. But I think like we already discussed, it can be more thorough for that part. That's all.
Okay lah, Hassan.
Yeah.
Provisional differential comments. Lepas ni Nur Zakira. Lepas tu Nur Hazika.
Provisional diagnosis is provisional diagnosis is migraine-induced seizure.
Huh?
Migraine-induced seizure. The patient have headache for a long time. Then you need to ask the patient whether ada headache tak before or during or after the seizure. And points 4, the history of long time of headache on and off temporary, and points against, dia tak ada aura, and there is nausea, nausea vomiting ada ke? Tak sure. Tak tanya nausea vomiting. Tak. Apa lagi? But there's no the previous diagnosis of migraine, so points against, yes. And no, for neurological symptoms, the not so much in the physical examination, and there is also no family history of migraine.
Okay, differential.
Differential diagnosis is epilepsy, the first episode of epilepsy, and in phase 4 is presented with tonic-clonic seizure, and there was however there was no triggering factors such as flashing lights or sleep deprivation. There is less likely to be meningitis because of no fever, no neck stiffness, and no tak sure.
Sudah. Berapa je differential ni? Satu je.
Satu je. Sekejap.
Comment, tak apalah. Comment on his presentation.
Presentation
Ada ni Syah, your colleague semua struggle nak dapat differential ni. Cepat Asad, comment.
Comment presentation smooth presentation, but smooth maksudnya tak ada, macam mana compare saya lah. Teman. Sekejap. Some parts dia kena clarify balik, so macam yang apa yang doktor tanya tadi, semua apa yang buat semua tu, tapi rest tak ada systems, tak banyak sangat elaborate apa yang not unremarkable tu macam mana.
Masalah. Again, sometimes we don't comment, not because it's not good, because we also don't know what to comment. So again, it assess both the presenter and the listener as well. Okay, Nur Zakira. Lepas ni Nur Hazika. Lepas tu Nur Alia.
Tadi dah. Tadi saya dah buat dah.
Oh dah, terlepas. Okay. Nur Hazika. Lepas Nur Hazika, Nur Alia. Provisional differential comment.
I think the provisional would be status epilepticus because the presentation of the seizure is more than 5 minutes and it is
Status epilepticus is a presentation, not a diagnosis. Well, it should be part of the diagnosis. So status epilepticus due to something.
probably due to headache. I think
So diagnosis is headache.
think that okay, I think the the it will be status epilepticus secondary stroke due to hypoglycemic
So
because
sometimes how you would say is hypoglycemia with status epilepticus, febrile seizure with status epilepticus, meningitis with status epilepticus, macam tu.
so hypoglycemic with status epilepticus for the first the provision diagnosis. For the differential, it would be first epilepsy. This might be the first presentation, and need to investigate further for the triggering factor. And then the second provision, the second differential would be space occupying vision, because patient complain of headache for 1 year with increasing intensity, so probably they are causing seizure. And the third one would be, I think the third one could be infectious, such as meningitis or encephalitis. However, with no fever and negative finding of the neck stiffness and central nervous system, so it might be below. And then it can also be due to febrile seizure, because he had his family history with febrile seizure. The last one could be
Okay lah, fine. Comment.
Comment. The history is, I think the history is okay, but it needs more detail on the seizure chronology, and also to other features of to features that could rule out the differential diagnosis. That's all.
Okay, Alia. Nur Alia, provisional differential comments.
Okay, so for my provisional diagnosis,
Banyak
it
buku
is
belakang tu. Saya expect dia power sikit.
background. Okay, so it is a status epilepticus secondary to undiagnosed space occupying lesion, because a patient had headache for more than 1 year, which is quite chronic, and then ada vomiting, but I would like to inquire more on if there is any retarded growth, like failure to thrive, or any other constitutional symptom, and other symptoms such as any syncope, blurring of vision, and change in personality or memory. So for other diagnosis, so the first one is status epilepticus secondary to structural abnormality in the brain. If there is the patient have something like abnormal in the brain that is hereditary. The second one, if there is any metabolic derangement like hypoglycemia, hyponatremia. The third one, if there is any CNS infection, which is not likely because there is no fever and no other sign like Brzezinski and Koenig sign. The fourth one is febrile fit. However, it is not likely also because of the age and there is no fever. And the fifth one is epilepsy. However, it is unlikely also because there should be 2 unprovoked seizures. So for comments, it is quite comprehensive. However, it could be better if the presenter could elaborate more on the headache, the severity, and does it has been investigated or diagnosed before, or does the patient have gone to hospital to be investigated? Okay, that's all.
Okay, I think let's get back to the presenter lah. Presenter, what is your probation analysis and what are your differential diagnosis?
Okay. Okay. This is wrong. As mentioned by Dr. just now, status epilepticus is
Condition.
it's not a diagnosis. Yes. So so my provisional diagnosis is I think epilepsy, because this person have a first episode of unprovoked seizure. However, from the definition in the protocol, it can be 2 or more episodes of unprovoked seizure, or only one unprovoked seizure with a high risk of another episode of seizure. And then so points against is this patient have no family history of epilepsy. So my differential diagnosis includes as mentioned just now, meningitis or encephalitis. So for points 4 is the patient have a history or have a presentation of tonic-clonic seizure, and also one episode of vomiting. Points against is 1 year history of headache, and there is no history of fever, no history of photophobia, no history of neck stiffness, and on examination the Kernick and Brudzinski sign is also negative. So for my second differential is space of explanation or tumor. Points 4 is again the patient have a 1 year history of intermittent headache, and also seizure. However, for points against is because this patient have no history of no family history of malignancy, and also no sign of no constitutional symptom like loss of appetite or loss of weight that suggests malignancy. And then my third is hypoglycemia with status epilepticus, because of point 4 is this patient last meal is 11 hours ago prior to the seizure. And then electrolyte imbalance like hyponatremia. However, this patient have no history of diarrhea or polyuria or excessive fluid loss. And then other than that, CNS central nervous system lupus, which can which is a presentation of SLE that can affect the neurological system. However, this patient have no sign like other sign like rash or joint pain. And then last but not least is trauma. However, this patient have no history of trauma.
Okay. Before we go to the next discussion, my comment on your presentation. I think your presentation is not enough actually. I know this is not your cracking. This is what you got from the case presentation. But I would expect case presentation should be better than this lah. Because I think the history is not enough. When you present a child with seizure, again, as I said, you can only ask appropriate question if you know the differential well. You can only present well if you have good grasp of all the differential diagnosis. Like if you think it's brain tumor, if you think it's space occupying lesion, there are so many other important history that you should have presented. Because this child, there are some suspicious history. Like you say, headache mainly over the right side, and then the seizure itself has some degree of lateralization, because the eyes focus to the right side, isn't it? You did say there's right gaze towards the right, so there is some element of lateralization. So it's not clearly. So is it straight away generalized seizure, or is it focal and then become generalized? What is it? Because usually generalized seizure shouldn't have any lateralization. It should be central. So it's not focused to one side or whatsoever, because if it's focused to one side, probably there's a specific lesion on one of the sides. So benda macam tu yang nak kena tengok. So history of other history that may suggest is some brain tumor or any space occupying lesion. Dia ada history of sunset eyes ke, kan, characteristic of the vomiting, headache punya history. You need to get more history of the headache itself, since when, berapa lama, selalu dia buat apa, how bad was the severe. So you did mention 6/10, but how significant is it? Is it briefly saja? Apa trigger dia biasa? Okay tak? Dia boleh pergi sekolah tak? Attend assembly tak? Apa lagi dia buat? Dia ada involved in any school activity? Dia main sukan apa? Dia main rugby ke? Dia main apa? Ke dia tak ada main sukan apa-apa langsung? Did the child involved in any, sebenarnya you main rugby, sometimes you getting head injury main rugby, atau main sepak takraw ke, atau main bola ke, sometimes that's quite common as well, isn't it? So is there any, what does the child do at school? What does the child do at for his hobby? Pertama-tama dia main apa? How does he behave with his other colleagues in school? Colleagues at home? Kan, kat rumah dengan siblings dia macam mana? And you need to get more of those history. Any constitutional symptoms, could it be TB? Kan? Ada history, ada contact with someone with TB tak? Could it be something like that? If hypoglycemia, what are the symptoms of hypoglycemia sebelum dia dapat seizure? Dia kan jadi lethargic dulu apa semua kan? So you just mentioned well prior to until day of admission. Tapi how well was he? Kan, sebab if hypoglycemia before seizure, dia akan ada few other symptoms yang lain kan? Dia akan jadi lethargic kan, at least dia akan jadi lethargic kan. So and then improvement pula, and then okay, I did ask what happened before the seizure, what happened in between the vomiting and the seizure, what happened masa seizure tu, apa parents buat kan. Parents bawa pergi hospital, okay fine. Adakah masa parents angkat daripada kereta masuk ke dalam ED tu, the child is still having seizure ke tak? Lepas tu dekat ED apa buat? Kalau macam parents boleh masuk sekali dengan patient, most likely it's not that bad. Sebab kalau patient teruk, what will happen? Doktor akan terus suruh patient tu duduk parents duduk luar, bawa masuk patient dalam ED. Kan? Berapa lama pula patient tu dekat ED sebelum naik atas? Sebab kalau simple case, tak ada apa-apa masalah. Kan? Dia bagi treatment terus okay, terus seizure stop. Kan? Cepat naik ward. So you know it's not that bad. Tapi kalau macam patient dia nak kena buat banyak prosedur kat bawah, difficult line, aborted pula lambat, bagi Valium tak aborted, bagi phenytoin tak aborted, bagi ni tak aborted. So you know probably the child presented in quite a bad situation. Ada cyanosis ke tak kan? Lepas tu pula masa naik ward tu dia ada berapa line? Satu line je kat tangan ke, ataupun ada sampai 3 line, sampai femoral line. So you know probably the child came in quite a bad condition. Kan? Apa lagi? You this case presentation dia cakap tak dia kelak tu dia berapa of admission?
It's not mentioned on what
so is it important?
Yes, it's important.
It's very important. When do you clock the patient? Because if you clock the patient after a few days, there's so many other things that has been done. But what was the treatment done in the ward? Did they start on antibiotic? Did they discuss with the parents about lumbar puncture, for example? Because if they think about meningitis, they sometimes will do lumbar puncture from ED, bukan dekat atas. Kat ED pun dah buat lumbar puncture. Have they thought about that? So these are the things that you should have asked lah. So macam tu. Faham? So I think in history wise, that's not enough. This one is not a good case presentation. Okay. Alright. Let's go to your management.
Doktor, nak tanya.
Yes. Masyara.
Kalau dia kan adalah 4 out of 6 siblings, and the social history of the parents is not financially stable, boleh ke saya nak tanya, can ke kalau my professional diagnosis more to like negligence or malnourished?
Negligent.
Huh?
Negligent.
Ya Allah. Negligence. Boleh ke?
Well, you need to think of that lah. If there is some element, if there is any element of negligence ke apa ke?
Maksud saya, what I mean is, can that be a trigger to seizure? Is that, or is it just a minor thing?
No, it's important. Social histories are important. But the thing is, if why negligence causes seizure? So malnourished itself doesn't cause it. Okay, malnourished can cause like hypomagnesemia, hyponatremia, and so on and so forth. Yeah, so it is part of that. So you need to ask like, if you think there is element of negligence, then you need to so it should be part of your thinking process lah. Non accidental should always be part of your thinking process.
Okay, thank you.
Okay, Shah, how would you manage this patient?
Okay, how I personally how this patient was managed in the hospital.
How would you manage this patient?
So me because start manage the patient start when the patient arrived at the ED department lah. So usually in the hospital we need to first as always the ABC, ensure the airway, breathing and circulation. We should insert we should have access to the IV access and insert Branula for administration of medication. So since this patient is already more than 30 minutes of episode of seizure with incomplete recovery, so I think we can start with intravenous phenytoin. And then
do you know the dose? What would be the dose for phenytoin? Loading and also maintenance.
$20 milligram per kg.
That is for?
Loading dose.
Over how long?
Over 20 to 30 minutes.
Okay. Okay. Lepas tu maintenance?
Maintenance I'm not sure how the dose for maintenance.
Okay, maintenance usually you start 5 milligram per kilo into divided dose. Okay, what else? Antiepileptic lagi?
And then give IV fluid to this patient. And then we should also give empirical antibiotic to cover for if we suspect of meningitis.
Okay.
And then which other than that, for non-pharmacological management, I think we should, since this is the first episode of seizure and this patient, we should educate the patient about how to manage or how to respond to maybe a subsequent episode of seizure.
Okay, what else?
And then okay, since management also includes the investigation, then I would like to also do certain investigation to find the cause of the seizure itself, like CT scan of the brain and also EEG.
Okay. Lagi?
Yes, I would like to also send for other blood for other lab investigation like full blood count, and also most important is because this patient is suspected for having hypoglycemia with status epilepticus, so we do blood glucose test, random blood glucose or dextrostric, and then we also send for other investigation like lumbar puncture, as you mentioned earlier, in the ED can be done, and then baseline investigation like liver function test, and also renal profile. In case of electrolyte imbalance, they can have low.
Why liver function test?
Liver function test is done because I think it's a baseline because certain drugs, antiepileptic drugs, can cause hepatic toxicity.
Yes, that's very important. It's a very important factor. Almost all antiepileptic drugs are metabolized by the liver.
I think that's all. Otherwise, for blood count, we like to also look for evidence of infection in meningitis or encephalitis. I think that's all for this session.
Macam mana ni? Macam ni? Okay, tak apalah, tak apa. First presentation. Okay. Still acceptable. There's so many areas need to be improved. I think again, case presentation, history tu banyak tak cukup. Physical examination. One I want to say is, if your diagnosis is something neurological, your neurological presentation should not be just like that. If your diagnosis is something neurological, when you present your physical examination, the neurology should be more detailed. You tak boleh lah, okay, tone normal, power normal. No, that's not enough. You need to go more detail. Cranial nerve dia macam mana, neurological tone kat mana, reflexes mana. You need to go more detail lah. Tak boleh superficial because your diagnosis is something neurological. If your diagnosis is something cardiovascular, your cardiovascular presentation should be detailed. Your developmental history should be more detailed. Your social history should be more detailed because it is neurological. Kan? So physical examination is not enough. I always advise students, do not do shortcuts. Don't do shortcuts. Shortcuts are for consultants. Dah jadi consultant nanti, lepas jadi specialist boleh jadi consultant. Jadi consultant nanti you nak shortcut, tak apa. When you're a medical student, don't do shortcuts. Present thoroughly. It's okay to be thorough. It's good to be thorough. We like you to be thorough. We don't like you to be shortcutting everywhere and anywhere. And shortcuts are for consultants. Don't do shortcuts. Kalau masa medical student dia biasa shortcut, nanti masa jadi consultant nanti sepotong sepatah perkataan dia. Don't do shortcuts. So physical examination, you must be thorough. Kalau you don't have time, that you need to shortcut because you don't have time, your presentation has been too long, then at least bila orang tanya, you need to be able to answer and give the lengthy explanation lah. Okay, fine. And then the way you answer in terms of management pun, I think that's not satisfactory lah. Kena ada flow sikit. Maknanya how would you manage? So okay, again A, B, C, but you need to go more detail. A nak buat apa, airway nak buat apa, breathing nak buat apa, circulation nak buat apa, how you stabilize the patient in ED, and then how would you do in admission kat ward, you nak buat macam mana, by the time monitoring how frequent. But because your management is not just what you are going to do as doctor, but what the nurses should do as well. Because you determine how frequent the nurses will do by the time monitoring. You will determine where the patient will be admitted. Open ward, acute bay, HDU, PICU, you determine. Drip, you nak keep needle by mouth ke tak? You nak buat monitoring apa? Nak buat feed chart, nak buat apa chart? IO monitoring. All those monitoring is determined by your management. It should be part of your management. So when you plan for the management, you need to tell lah what you want to do. What you want to monitor, what you want the nurses to monitor. You tak boleh assume nurses tahu terus. Patient admit, oh nurse boleh tahu baca apa yang doktor nak. No, we need to tell them clearly what we want to do. So we need to, I think in terms of management part tu, you kena be more detailed and more thorough lah. Kena more thorough. Tak cukup macam tu. Okay, I think it's already 1.5 hour, and I think I don't think I have enough energy to proceed lah. I'm very sorry. I'm not well. I haven't been to work since morning. Budak ni pun tak apa sihat. And I think we should stop here. I think I need to go and get some paracetamol or something already. Tadi sakit kepala. Dengan you present lagi sakit kepala lagi sikit. Okay, alright, fine. Tak apa. There's so many room for improvement still. We're still early. Again, we can arrange other session as well lah. Kalau I don't know whether do we have any other session with you in the timetable or not. Kalau tak ada, you can just get back to me. I don't mind arranging other slots lah. But again, I don't have that much time. Banyak ni pun ada hutang lecture dengan group mana tu. So I think still you need to but again, you can contact me, ask me when I have time, then we can arrange extra teaching sessions. I don't mind. Okay lah, macam tu. I think we really need to stop now. Unless there's any other burning question ke apa, ke tak boleh tidur malam kau tak tanya. Tak ada. Semua pun dah penat dah. Okay lah, let's end here. Let's end with tasbih kafarah.